Hello and welcome everyone. We are in week 6 and lecture number 27 of the knee rehab course. Today's lecture is on rehabilitation strategies for LCL and posterolateral corner injuries. The objectives for today's lecture are to review the anatomy and biomechanics of the lateral collateral ligament, or also known as the LCL ligament, and also that of the posterolateral corner, also called the PLC. To understand the mechanisms, grading, and clinical presentation of LCL and PLC injuries. We will also learn the phase-wise rehabilitation strategies for isolated LCL cases and recognize key principles and modifications in rehab after PLC reconstruction. We shall also learn to apply criteria-based progression for safe return to function and sport. So let's begin. In the previous class, we studied about MCL injuries. LCL and posterolateral corner injuries don't get talked about as much as ACL or MCL, but they are just as critical. Overlooking of the PLC injuries can lead to chronic instability and poor rehab outcome and prognosis. The rehabilitation in such injury is slower, and hence patient counseling is important to maintain patient compliance throughout the rehabilitation process. Because a poor rehab will prevent long-term disability in patients. As discussed in week number 1, the LCL runs from lateral condyle of the femur to the fibular head, acting as the primary restraint to varus force and stress. Varus force is directed from the inner aspect of the knee to outward aspect of the knee in the frontal or the coronal plane. An LCL injury can be seen in both contact and non-contact sports. The posterolateral corner is a complex of structures like ligaments, tendons, and capsule in the back and outside of the knee. These structures include the popliteus tendon, the popliteofibular ligament, and arcuate ligament complex. These structures together provide stability against varus stress, which is the inward bending of the knee. It also provides stability against external rotation, and their role is critical when combined with cruciate injuries. Now, as seen in the previous slide, we already know that a varus force will lead to LCL injury. But varus force alone may cause a low grade LCL injury. A high grade LCL injury along with PLC injuries usually results from a varus force which is combined with hyperextension and external rotation of the knee. Contact injuries are common in sports like football when the medial aspect of knee is struck either with an object or on collision with an opponent. High energy trauma, such as motor vehicle accidents, also can cause these injuries. Importantly, LCL and PLC injuries are often associated with ACL or PCL tears, making the diagnosis challenging. In a 10-year study of athletic knee injuries, LCL lesions made up 1.1% of sports related knee injuries. Sports with high pivoting, contact, and direction change, like soccer, tennis, gymnastics, showed more of these injuries. In men's professional soccer, LCL injuries more often occur during matches and with contact mechanisms. About 7 to 16% of knee ligament injuries involve the PLC complex. Brazilian Jiu Jitsu, soccer are the prominent among these, and so are contact and varus hyperextension injury mechanisms. These injuries can easily be missed, and if not handled right, they lead to chronic instability. Rehab here has to balance protecting healing of these structures with gradually restoring their function. Because of the complexity of the posterolateral corner, progression often needs to be slower and more cautious. Getting this right is key to preventing long term disability and ensuring return to sport. The grading of LCL injury is quite similar to MCL injury grade. Grade 1 LCL injuries show mild tenderness and less than 5 mm opening, with the clinician providing a valgus stress at 30 degrees of knee flexion. Grade 2 injury shows partial tear with 5 to 10 mm opening and a firm endpoint. Grade 3 indicates a complete tear with more than 10 mm laxity and no endpoint. As discussed previously, no endpoint means a complete rupture of underlying ligament. For PLC injuries, to identify instability, we use the dial test, the posterior lateral drawer test, and reverse pivot shift test. I encourage everyone to look up on the net the method by which these tests are performed. A positive test usually means a PLC injury along with a cruciate ligament injury. Most isolated grade 1 and grade 2 LCL injuries are managed non operatively or conservatively. The key is short term bracing with protection against varus forces, that is, forces directed from inner aspect to the outer aspect of the knee. Range of motion is restored early but in a controlled fashion. Muscle strengthening focuses on strengthening of quadriceps, hamstring, and hip abductors. Hip abductor strengthening supports lateral stability of the knee. Conservative treatment usually yields excellent outcomes for grade 1 and 2 injuries. In this early phase, let us recollect the police protocol, which was protection, optimum loading, icing, compression, and elevation of the limb. Our initial aim is to reduce pain and swelling with icing and compression. For controlled range of motion, a hinged knee brace protects against varus stress, usually locked at 30 degree of knee flexion. Partial weight bearing with crutches is allowed in this phase. Isometric activation of quadriceps, hamstrings, and glutes helps maintain strength without stressing upon the ligament. The criteria to progress to the next phase includes the pain and swelling to be fully controlled, full knee extension and knee flexion of more than 90 degrees, straight leg raising without any lag, and a stable gait while walking with brace. In this phase, range of motion exercises are gradually introduced, aiming for full motion by week 6. Strengthening shifts to close chain drills like mini squats. Core and hip strengthening are emphasized upon. Glute bridges are the exercise that can be done once the range of motion of the knee is till 90 degrees. Balance and proprioceptive training are added to improve neuromuscular control. patients remain in a functional brace during walking and other activities of daily living. The criteria to progress to the next phase include restoration of complete and pain free range of motion, muscle strength of the injured limb to be more than 75% of the contralateral or uninjured limb, no varus laxity or instability should be present on performing functional tasks. A balance of more than 20 seconds in single leg stance should be present. In this phase, we integrate lateral movement patterns, agility drills, and eventually light plyometrics if the patient is pain free. Neuromuscular training ensures proper knee alignment and also helps control under stress. Progression is criteria based, requiring adequate strength and no instability before advancing. The criteria for clearance for the next phase includes strength of more than 90% when compared to the contralateral or the uninjured limb. Hop test should be more than 90% when compared to the uninjured limb. No pain or instability should be present during lateral agility drills, and the clearance should be given by a sports medicine specialist. In the previous slides, we discussed rehab of grade 1 and 2 injuries. Now we shall discuss grade 3 injuries. Surgery is required for isolated grade 3 LCL injuries. Surgery is also required for combined injuries of LCL with the cruciate ligament, or if there is presence of significant PLC injury. A common indication for surgery is persistent instability despite conservative care in athletes. An injury to PLC usually requires a surgical management because conservative management isn't able to provide the stability that is required by the athlete. PLC injuries left untreated can compromise cruciate ligament grafts. Hence, surgical reconstruction is often advised and practiced. After PLC reconstruction, the rehab is slower and more cautious for as compared to an isolated LCL injury. The focus is on limiting the range of motion initially. This is done to protect the graft and allow it to heal properly and adequately. Hyperextension of the knee must be avoided in this phase. Weight bearing is often restricted for 4 to 6 weeks. Muscle strengthening is progressed gradually, but resisted hamstring activity is delayed to protect the popliteus. Return to sport usually takes about 9 to 12 months. Return to play or return to sport requires meeting strict criteria. Full pain-free knee range of motion, quadriceps and hamstring strength to be more than 95% of the opposite uninjured limb, and successful completion of functional hop and agility test. There is a difference between able to perform hop test and passing the hop test. The ability to perform hop test is a criteria for phase 3 of rehab, while the passing of test repeatedly is a criteria for return to sport. We will be discussing more about the functional tests in following lectures. Importantly, there should be no subjective feeling of instability experienced by the patient. The clearance must be provided by the treating physician. The key takeaway points are that LCL and PLC injuries are rare but critical to stability. Overlooking PLC injuries will lead to instability. Low grade LCL injury mostly requires a conservative rehab protocol. The PLC reconstructions rehab protocol is slow and a cautious approach. Criteria based milestones ensure safe and guaranteed return to sport. These are some of the references that I have used in the lecture today. With this, we have completed MCL, LCL ligament injuries and injuries to the PLC corner. In the next class, we will be discussing about PCL ligament injuries. Till then, thank you and goodbye.